Amyloidosis is actually a generic term that refers to a variety of conditions that are characterized by the pathologic deposition of a particular protein, known, not surprisingly, as amyloid, in the extracellular space. The appearance histologically is of an amorphous appearing, often pink appearing protein that is deposited in the extracellular space. Pathologists use a particular stain called a Congo red stain, which highlights the red or pink color of amyloid. Also, the Congo red stain, when viewed under polarized microscopy, gives the amyloid a particular color known as apple green by refringence. As you see in this next slide, the H&E slide demonstrates the red-pink deposition of amyloid around the blood vessels in this picture from the kidney. And then when the same slide is viewed under polarized microscopy, you see what we term the apple green birefringence of the amyloid deposited around the blood vessels and also within the extracellular space around some of the surrounding cells. Now, the term amyloid actually refers to a group of substances, there are over 15 known, that share a common structure that can be formed by a number of different proteins. On electron microscopy, what amyloid appears to be is it appears to be made up of non-branching fibrils of variable length with a diameter anywhere from 7.5 to 10 nanometers. X-ray crystallography and infrared spectroscopy has also been useful in the analysis of amyloid, demonstrating the creation of what we term a cross-beta-pleated sheet conformation, as you see in the picture that accompanies this slide, where a series of paired filaments congregate together to form amyloid protein chains, which are made up of the beta-pleated sheet. And this is where the Congo red stain that we mentioned in our earlier slide congregates and gives the apple green birefringence. Now, when we refer to amyloidosis, we can refer to either primary or secondary amyloidosis in terms of the way in which it can present in patients. In primary amyloidosis, we're referring to a condition where there is deposition of amyloid fibrils derived from Ig lambda light chains. You see the light chains there in our diagram showing an antibody with both the heavy and the light chains present. Now, naturally, as we're dealing with antibodies and the creation of light chains, the cells that are going to be involved here will be plasma cells. And thus, one should associate primary amyloidosis with various plasma cell disorders, including multiple myeloma, Waldenstrom's macroglobulinemia, and other B-cell lymphoproliferative disorders. Secondary amyloidosis is when one has deposition of amyloid fibrils derived from precursor proteins such as serum amyloid-associated protein, or as we refer to it in shorthand, SAA. You will see secondary amyloidosis in clinical conditions that are characterized often by things such as chronic inflammation. So think of secondary amyloidosis, for example, in patients who have chronic infections or some sort of autoimmune disease, particularly those in which there's tissue destruction that leads to increased amounts of serum amyloid-associated protein. Think about diseases such as Hodgkin's diseases with their complications, or renal cell carcinoma as conditions that may produce secondary amyloidosis. Another condition that is commonly associated with the deposition of amyloid is Alzheimer's disease, where what one sees in the brains of these patients at autopsy is the deposition of amyloid within the cerebrovasculature. Hence, a condition that is associated with Alzheimer's is known as cerebrovascular amyloidosis. You can also see the deposition in amyloid of brains of non-demented elderly individuals. And indeed, for those of you who go into areas such as neurology or neurosurgery, if you're ever dealing with an unexplained bleed in an elderly patient, here defined as someone over the age of 50, you should always ask your pathologist to do an amyloid stain to rule out the presence of cerebrovascular amyloid, which can weaken the wall of a blood vessel and lead to these catastrophic bleeds within elderly patients. The gene for the particular protein involved here is found on chromosome 21. Certain other conditions can lead to the deposition of amyloid. Medullary carcinoma of the thyroid leads to amyloid deposition from the overproduction of calcitonin in this particular tumor. And another very common condition that can lead to the deposition of amyloid is diabetes mellitus. In type 2 cases, the adult form of diabetes, you can see amyloid deposition in islets of the pancreas. This is thought to be derived from insulin or glucagon and is called amylin or islet amyloid polypeptide. There is a particular form of amyloidosis that also is associated with long-term hemodialysis. Here it is thought to be formed from beta-2 microglobulin, which is a component of the major histocompatibility class 1 molecules. And then you can also see amyloid coming from a normal serum protein known as transthyretin, or TTR. A mutant form of this protein is deposited in the familial amyloid polyneuropathies. This can also be seen in the amyloid that's deposited in the heart of elderly individuals affected with amyloidosis, a condition known as senile systemic amyloidosis. This next diagram in this slide simply demonstrates the structure of beta-2 microglobulin, with the various parts of this gene leading to the creation of various transmembrane proteins. So in summary, in the creation of the condition known as amyloidosis, there are various routes that can lead to amyloid being deposited in different parts of the body. There are various different stimuli. Some of these are unknown, although we assume that they may be related to different carcinogens that lead to various beta lymphocytes proliferations. This leads to the creation of plasma cells, which produce the immunoglobulin light chains. There is limited or incorrect proteolysis of these light chains, and one has amyloid protein deposited in the body. Remember, this is what we tend to term primary amyloidosis. In other conditions that lead to chronic inflammation in a patient, you have macrophage activation with creation of interleukin 1 and 6. Cells in organs such as the liver tend to be preferentially affected with deposition of usually large amounts of the SAA protein. Again, similar to what occurs with the immunoglobulin light chains, there's limited or incomplete proteolysis, and the AA protein becomes deposited in the extracellular space. Finally, yet another way in which amyloid can be deposited in different parts of the body is simply production of normal amounts of a mutant protein, an example here being transthyretin. In terms of what one will see clinically in patients who are affected with amyloidosis, there are several classic places in which amyloid will be deposited and which you may be tested upon in USMLE Step 1. Most common with AL, the AL form of amyloidosis, is the deposition within the heart, or the cardiac form of amyloidosis. The effect here, as one might expect with the deposition of an abnormal protein within what should be a very contractile organ, is a restrictive cardiomyopathy and congestive heart failure developing. On your EKG, you can see the creation of various arrhythmias that may result from this restrictive pattern. The kidney is also commonly affected in different forms of amyloidosis. Classically, the area within the kidney that is affected is the cortex, where what one sees is the deposition of amyloid within the glomeruli. Also, if one does a urinalysis on these patients, they are characterized by having a proteinuria, which can range from very mild to levels of protein that are consistent with the diagnosis of the nephrotic syndrome. And unfortunately, this deposition of amyloid leads to progressive renal failure that is not easily reversible. This slide simply shows the deposition of that pink-red protein that is amyloid within this heart specimen taken from an autopsy. You see the massive enlargement of the cardiac muscle and the dark red discoloration secondary to the deposition of amyloid. One can also see the deposition of amyloid in other organs in the body, and in those that you can discern easily on a simple physical exam. One of the most common places to see the deposition of amyloid when you're dealing with the GI system is within the tongue. And hence, if you see a patient who is affected by unexplained macroglossia, or enlargement of the tongue, put amyloid on your differential diagnosis. However, remember that any level of the GI tract can be involved, including the liver, and thus a variety of symptoms can be produced. One can also see amyloid deposited within the CNS. You can develop a peripheral neuropathy as different nerves are affected by the deposition of amyloid. The patients can develop a postural hypotension or an unexplained carpal tunnel syndrome. And again, also remember the deposition of amyloid within Alzheimer's disease, within the cerebrovasculature, and its possibility as an etiology for otherwise unexplained cerebrovascular bleeds. Now, how do we go about diagnosing amyloidosis if we suspect it in a patient? Most commonly, you'll ask your surgeons to do a biopsy of the rectal mucosa, the gingiva, again remembering that amyloid can affect various areas of the GI tract, including the tongue, or perhaps most commonly, the abdominal fat pad. Here again, the pathologist must sometimes be reminded that amyloid is in the differential and that they should either do a Congo red stain to look for amyloid or use some of the various immunohistochemical stains that are available today against the various amyloid proteins. Unfortunately, the treatments for amyloid and amyloidosis are rather limited. In essence, if you remember what we've talked about at the beginning of this lecture, amyloidosis is the result from another specific condition, often a chronic inflammatory disease or some other underlying condition within the patient. Hence, in order to treat the amyloidosis, what one should do is treat the underlying condition, depending upon the etiology. If the patient's heart is affected, as you remember in the slide we saw a few moments ago with the restrictive cardiomyopathy, one should think about cardiac transplantation, and in patients whose kidney is affected with deposition of amyloid within the glomeruli, renal transplantation is sometimes an option. However, remember, if you have not treated the underlying condition that's leading to the deposition of amyloid, these new transplanted organs will eventually be affected as well by the deposition of amyloid within them. Thus, overall, unfortunately, for many of these patients, the prognosis is poor, with their lifespan limited to 1 to 3 years after the initial diagnosis. This concludes this section on amyloidosis for Falcon Review of Pathology for USMLE.